It was a quiet evening in the emergency department when Mrs. Harper, a 45-year-old teacher undergoing chemotherapy for breast cancer, arrived in the emergency department with her husband. She looked pale and fatigued, and her temperature was elevated at 38.5 degrees Celsius. Dr. Patel, the on-call oncologist, greeted her with a reassuring smile, though his concern was immediate. "This looks like febrile neutropenia," he thought. A quick blood test confirmed a neutrophil count of 0.3 times 10 to the 9th per liter, placing Mrs. Harper in the high-risk category. Dr. Patel acted swiftly. "We need to start broad-spectrum antibiotics immediately," he explained to his team. He ordered piperacillin-tazobactam, a trusted antipseudomonal beta-lactam agent, as monotherapy to cover gram-negative, gram-positive, and anaerobic bacteria. While reviewing her history, he noted a central venous catheter but no redness or signs of infection at the site. "Vancomycin isn't needed right now," he explained, "but we'll monitor for any signs of a catheter-related infection or hemodynamic instability. Let's also get blood cultures and a chest CT scan to rule out pneumonia or other complications," he added. By the 4th day, Mrs. Harper was still febrile but otherwise stable. Blood cultures showed no growth, and the chest CT scan revealed no significant findings. Dr. Patel reassured the family, "Persistent fever alone isn't a reason to change her antibiotic regimen since she's stable." He began considering fungal causes, knowing that prolonged fever without a source could signal an invasive fungal infection. By day 7, Mrs. Harper remained febrile. A repeat CT scan showed a small pulmonary nodule, raising concerns for invasive mold infection. Dr. Patel immediately broadened her treatment. "We'll add a mold-active azole like voriconazole," he said, explaining the risk of invasive aspergillosis in neutropenic patients with pulmonary nodules. "We'll continue piperacillin-tazobactam for bacterial coverage and add the antifungal to address possible mold infections," he explained to his team. When the fungal treatment began, Mrs. Harper started to improve. However, a new development arose: redness and tenderness at her central venous catheter site. Blood cultures from the catheter grew Candida albicans, confirming a catheter-related bloodstream infection. Dr. Patel acted decisively. "We'll remove the central venous catheter and adjust her antifungal therapy to caspofungin," he announced. The combination of catheter removal and antifungal treatment brought significant improvement within 48 hours. By day 10, Mrs. Harper's fever resolved, her neutrophil count began to recover, and her energy returned. She was discharged with a follow-up plan and a grateful smile. Her husband thanked the team, saying, "You saved her life with your careful decisions." Start empiric monotherapy with an antipseudomonal beta-lactam as piperacillin-tazobactam for high-risk neutropenic fever. Add vancomycin selectively for central line infections, pneumonia, or hemodynamic instability. Persistent fever alone in a stable patient does not justify altering the initial regimen. Add antifungal agents for persistent fever after 4 to 7 days. Select the agent based on suspected fungal pathogens, as Candida or molds. Remove central venous catheters and bloodstream infections caused by the Candida, Staphylococcus aureus, or Pseudomonas aeruginosa. Dr. Patel reflected, "This case reinforced the value of evidence-based decisions and targeted interventions. Precision in therapy saves lives while minimizing unnecessary risks." Subscribe to the Infection Tube to explore more stories of clinical precision and the science behind saving lives. Together, let's master the art of antibiotics.